Good morning, friends. It gives me a great pleasure on Sunday morning to give you some very important information and certain pearls of wisdom on a very important therapy in diabetes, that is insulin. Insulin has made changes in the lives of diabetics, millions of diabetics, and diabetics are not only living longer, but they are living comfortably without much of morbidity or complications or suffering. And therefore, we should know a great deal about this wonder drug and how it is to be initiated, how it has to be monitored, how it has to be given in various conditions, and what is the best way of giving it, and how you can make your patients compliant by taking injections. Now, at the outset, let me tell you that when you talk in the management of a diabetes, and particularly type 2 diabetics, who come with the symptoms of high sugar such as excessive urination, thirst, or some of them may not have any symptoms also. They are routinely diagnosed in a preoperative test or maybe for some other condition when they are being evaluated. So those people are quite comfortable, and in fact the whole idea of going to a doctor, the entire role of a doctor in society is a person who gives you a pill and makes you all right. That could be a broader definition of a doctor, particularly in a chronic disease management. All that people want is some kind of a pill or a tablets, and they should live a symptom-free life, complication-free life, and should be able to carry on with their daily activities. The treatment part should not interfere with their lifestyle, and that is the idea of most of the patients with type 2 diabetes. Now, this works in quite a few patients, that the patient comes to you with an elevated blood sugar, with associated mild comorbidities such as hypertension, ischemic heart disease, and we give them a lifestyle change. We say, look here, now you have to get your diet under control. You see that this controlled diet reduces your weight, your waist circumference must come down, you should feel more active, you should remain more active, you should do a lot of physical activities. So there is a change of dietary lifestyle, and that sometimes becomes difficult for some people. They have never behaved in such a disciplined manner, and that's a time when some of them are compliant because they say, well, it is better than avoiding, better than taking injection, and the doctor has given me a pill to reduce my weight, to reduce my appetite, and given me a very simple change in lifestyle, not so difficult. Let me try it. And sure enough, about 30 to 40% people do benefit initially. And the initial enthusiasm of controlling their diet as well as doing physical exercise is quite rewarding. And many of them knock off about a couple of kilos of weight, their blood sugars come down, they feel well, and they feel, well, this is a good lifestyle. When a time passes, after say 6 months, 1 year, this lifestyle modification alone is not adequate. Then there are pills available. Now, today there is an explosion of oral drugs. There are about 10-15 different types of medicine available now. When we were resident doctors, we had only 3 drugs to give: metformin, sulfonylurea, and acarbose. Therefore, obviously now with the modern pharmacology and modern drug therapy, there are so many drugs available, and they act at 12 different levels, because today they find they have found out that diabetes is a disease due to almost 12 areas which get affected, right from muscle, fat, brain, appetite centers in brain, the utility of the carbohydrates, the absorption of carbohydrate. So these are the 12 areas, we call them dirty dozen. And these dirty dozen areas can be manipulated with various drugs. There are beautiful drugs available which will intervene at that 12 areas, and they do show results. So what are the targets that we want our diabetic patients to come? We have a strict biochemical targets. They are fasting blood sugar, postprandial blood sugar, and there is a 3 months average test known as glycosylated hemoglobin or HbA1c, which tells you what should be your sugar in the preceding 3 months. Once these three targets, we call them biochemical targets, they come under control. Say fasting sugar is less than 120, post lunch sugar less than 140, HbA1c less than 6, and this is the target. 3-4 months later, many patients do come under these targets. They maintain that, but there is a possibility of a good control of diabetes with the help of weight reduction. Some of the drugs can be weaned off. Patients actually can go into what is known as a reversal of diabetes or remission of diabetes. And therefore, there are a lot of patients who are enthusiastic initially. They do take exercise, they do follow diet, they restrict from all their favorite dishes, they avoid sugars, they avoid simple carbohydrates, they avoid alcohol, they increase more physical activities. But this enthusiasm, we feel that after a period of years, somehow slows down, in the sense that people get fed up with the same type of disciplined life. One thing is there, a disciplined life has to be a matter of habit. It should be started in the childhood. Childhood, we are under control of our parents, teachers, school, and we are more disciplined. As we grow older, we go to college, then the discipline is lost to a certain extent. Late nights, movies, occasional drinking beer. Then you become adult, then there are a lot of work pressures, and there are job pressures. There are job opportunities which increase with cocktails and dinners. Traveling, airline traveling, that's another area where there are a lot of indiscretions take place. Airline food, timing of flights. So it disrupts your regular discipline. And therefore, to remain disciplined for the rest of your life is quite a tall order. And about 40% people fall out from that. And they need somebody like a school teacher throughout their life. Either the school teacher behavior could be from a very demanding spouse or a very demanding doctor. You can change the doctor if you don't like him because he's too strict and too disciplined, but you cannot run away from your spouse. And the third person you cannot run away, third thing that you cannot run away, you can divorce your wife. The third area where there is no escape is diabetes. Diabetes is your lifelong partner, and the best way to become its friend rather than having any enmity with it. So now time comes, the doctor sees the blood sugar report, fasting more than 200, post lunch more than 230, 240, with a waist circumference of 90 centimeters. The patient has actually gained weight and patient is lethargic. He has got many symptoms which cannot be really defined. One of them is malaise, tired, no interest, no enthusiasm, lack of sleep, body ache, gaseous distension, all vague symptoms. You know it's all because of elevated blood sugar. And obviously 4 or 5 tablets are not acting at different level. Conventional, we start metformin, then add sulfonylurea, then add acarbose, then we are now new generation drugs like gliptins, gliflozins. These are the drugs which have started, but they are not showing adequate biochemical results. And as an Indian description of a personality of a diabetic patient, we call Indians as a thin fat Indian. What is this thin fat Indian concept? At a BMI, body mass index, which is the weight divided by your height, at a BMI of 21, which is not obese, which is non-obese. But at BMI of 21, Indian phenotype classically has a waist circumference more than 88 centimeters, 90 centimeters. So entire weight of this gentleman is in the abdomen. Unlike his Caucasian counterpart, the Caucasian parts are broad shoulder, big muscles, waistline is still fully, although they are 10 kilos overweight, but their weight is distributed in muscles, while Indians tend to gain their weight in the abdomen. Now this is a very big risk factor. This risk factor predisposes a diabetic patient to premature atherosclerosis and coronary artery disease. And I always say diabetes and heart disease are two faces of one coin. And that is a typically Indian genetic disposition. And that is what now we have to control. What is in our hand right now, after having tried to reduce his weight, trying to change his lifestyle, to make him more physically active, we have no alternative but to put him on insulin. Now, if there are some skills a good doctor has and his ability to convince a person and his ability to create a faith in him that the patients follow his advice like a gospel truth. They say what Dr. Bhoraskar has said is the final word and I will go by what he said. It all depends on number of years that you spend, your personality and your sincerity, and the patient realizes that this chap is in interest for me and whatever he is doing it for my good. Once you have this faith, then the patient does not accept any form of treatment that you are giving him, particularly in a chronic disease management. Please remember, in a chronic disease management, I get many patients who come to see me. They have files of 10 diabetologists. I am the 11th one. And there is nothing wrong, because they like to go from doctor to doctor with the hope that this doctor will give me something better, something easier. And all the previous doctors have given right treatment, not that they give wrong treatment. But with the hope, the patient comes to you that this man will try to do something new and something simple. So that is the time when patient comes and sits with you with that kind of biochemical parameters. Then you look at him and you tell him, now look here friend, there is no alternative, but you will have to take insulin. The moment you take the name of insulin, there is a lot of discomfort. You can see both in the minds of the patient or his spouse or his relatives, and many of them actually get up from the chair. With a very reluctant mood, they sit back again because they have paid my fees already. The point is, now they have no choice but to listen to me. So I tell them, look here, first, why do you need insulin? So I tell him that what is the role of insulin in management of diabetes? What does insulin do? What are the metabolic activity? What are the things that you will benefit from insulin therapy? That is how people are convinced. Now you tell him that, look here, insulin will bring back all the important proteins which are lost from your body, and one of them is what you have is a sarcopenia. if you see the diabetics, their muscles are thin. Their muscle mass is lost. We call them loss of muscles is a sarcopenia. The weakness is because the muscle loses its meat. Now, by giving insulin, you are going to put that meat back. Muscles mass will increase, and therefore your energy level will go up. Your feeling of being tired all the time, and you're passing so much of urine because of excessive thirst and excessive urination, you're feeling tired, and when you're passing so much of urine, you're passing all vital structures from the body, including water soluble vitamins, sodium, potassium, and water, which are all, if you see human body, 80% is water. Now you are losing it, and obviously it will affect so many things. It will invite the trouble of coronary artery disease, it will invite the trouble of hypertension, and worst, you might develop kidney disease. And kidney disease now we see very common in type 2 diabetes in our country, which can be completely prevented. So once they hear all this, very reluctantly and very sad face, they accept it. Now is a time of taking their phobia out of their mind. You tell them that, look here, today the problems associated with injection and syringing and all this is gone. Gone are the days and that era where people had to boil needles and syringes. Then you take a bulb of insulin, then take out the insulin, take the injection. Needles were slightly thicker and they would get pain at the site of injection. Today, the technology is advanced so much. We have 32 gauge needles and a nano needle, small, less than half a centimeter. And they are so sharp that many times young children who are admitted in our hospital, initially they are very reluctant taking injection. You give them the injection in their sleep and they don't even wake up, because the sting of injection needle is smaller than that of mosquito. Mosquito bite may hurt you, but needle does not hurt you. Once the patient gets this feeling out of his head, see, injection always was looked at as some kind of a punishment, because the entire society used to teach as your child, if you're naughty and you're not studying or not, paying attention, and a doctor comes home to treat him for his cold and cough or treat some old man at home, they would say, "Hey, doctor ka kaya tha? Ye tula injection diti." The injection was taught from a childhood as some kind of punishment and some kind of a weapon, and therefore that phobia continues up to the adult. So once this phobia goes away, the patient becomes friendly with injection. He says, well, this doesn't look a big deal. And the site at which you take injection, on the abdomen, on the deltoid, very easily accessible parts, and you can keep on rotating these parts and start him on a smallest dose of insulin. Now, to understand exactly, insulin is after all a polypeptide. It's a protein. It has got two chains, A chain and B chain, joined by C peptide. And there is a lot of manipulation which can be achieved with genetic engineering. We can change one amino acid from one position to other and make many changes of insulin. Normally, your body makes insulin, endogenous insulin, the beta cell of the pancreas. As soon as the food starts going into the first part of your duodenum, small intestine, it sends a signal to pancreas that, look here, the food is going to go to the liver. So you start producing insulin. So there are beta cells. The three facts happen. The first is beta cells produces what is known as pre-pro insulin. Then it produces pro-insulin. And then the pro-insulin is converted into insulin, the final molecule, which is released into portal circulation to reach the liver when the food particle after being digested goes to liver for metabolism. This happens so precisely and perfectly. The timing is so great that no matter what technology we can do, we cannot match what God has done for us. But we try to do this, we try to mimic this physiological release of insulin. And therefore, all the manipulations that you do in the dosage and the timing of insulin is only to see that we achieve near normal insulin release like in a normal person. Now, this is known as PK/PD studies of insulin kinetics, that means time action profiles. When the injection is injected, from the time it is injected to reach the liver, and time it should get acted on the food stuff, that time frame decides at what time you will take the injection and what time you will eat the food. So this discipline of taking injection at a particular time, then eating food at a particular time, to go by the time action profiles of your insulins. Now, first remember what God has given you a signal, what God has given you a system. The insulin is produced in portal circulation. It's in the circulation near the liver, portal circulation. While when we inject the insulin in the skin, it goes into systemic circulation. Thereby, it first goes here, from here it goes to heart, from heart it goes distributed and ultimately reaches the liver. You understand the time taken for the subcutaneous injection to reach the site of action for the food to be metabolized. It has to go through this entire journey, and that is why that so-called time action profile, and that is the rationale of taking a short-acting insulin just not prior to meal but 20 minutes before the peak action of the food comes. So you take an injection about 15 to 20 minutes before you take breakfast. Now all these things is very, very complicated for a patient to understand. You take injection, then wait for 15-20 minutes. Your wife has brought some beautiful food. You cannot eat it because you have to wait for 10-15 minutes and everybody else is eating. So the smell is making you uncomfortable. But this discipline you have to maintain. Now that is the advantage of modern age insulin. It has cut short all these shortcomings of conventional insulin. Luckily there are 10 or 15 brands of insulin, and some of them are modern insulins. We call them analogs. By manipulation of certain amino acid, the PK/PD levels, the time action profiles have been altered to suit your requirement. Now there are rapid acting insulins, there are ultra rapid acting insulins, ultra fast acting insulin. Normally rapid acting insulin, the peak action takes place after 1 hour. Action is over in 5 to 6 hours. While the same action can be protected because body has got two states of insulin release. One is a basal insulin. What is a basal insulin? The pancreas keeps on producing insulin at a very slow rate for the whole day. It is known as basal insulin, which is irrespective to the food coming in or not. And therefore that insulin should continue at a very low rate and a low amount throughout 24 hours. Now to mimic basal insulin, they have to protract the action of insulin. So the insulin is made long acting by either combining with zinc, known as lente or NPH, or now with the modern genetic material, the long acting insulins are some modification of molecule. So it absorbs very slowly from the skin over a period of 12 to 13 hours, and the action is protracted for almost 18 to 24 hours. So single dose insulin works as a basal insulin, but basal insulin cannot fulfill the requirement of stimulated insulin release, because when you eat, you need a higher amount of insulin. To counteract the calorie load which is given for breakfast and lunch, you need a short-acting insulin just during breakfast and during lunch, and therefore many injections have a short-acting arm and a long-acting arm, basal, and a short-acting arm to act at the time of breakfast and lunch, so that your post-breakfast blood sugar and a post-lunch sugar comes below the age of below the level of 180. So this is achieved by these modern insulins. And now there is a co-formulations. Now what is a co-formulation? Co-formulation is not a mixture. Co-formulation is of the insulin which has a long-acting arm, basal, and a short-acting, quick-acting arm to overcome your post-breakfast and post-lunch sugar, and this is in a co-formulation. Co-formulation means there is not mixture. Each insulin has its own identity still left in that mixture. It's a mixture. A combination of short and long acting will not have their own identity of action. But the co-formulations, so nowadays the co-formulations are very popular, and you take a shot in the morning of a co-formulation which covers the basal insulin till evening, which covers postprandial fasting and post-lunch sugar, and maybe you need a small dose of short-acting insulin at night based on your dinner level. Now this has achieved a good control in 90% of the patient. Biochemical targets are met, but there are physical targets which also need to be observed at the same time. One of them is the patient of type 2 diabetes who is on insulin. He starts gaining weight. As the HbA1c starts coming down, a person starts gaining kg, and it is known as HbA1c kg paradox. Our entire objective of a type 2 diabetes is to reduce the weight, to reduce the waist circumference. But exactly opposite happens when the diabetes comes under good control. When the HbA1c starts coming below 6, which is ideal, the person gains 5 to 6 kilos of weight. But this weight is a healthy weight. It is in the form of muscles. But part of the weight also happens in your white cells of the fat, white fat of the abdomen, which is a very big risk factor, which makes you vulnerable to coronary artery disease, and that has to be kept in mind. And therefore, a person on insulin cannot forget to diet, cannot forget to do exercise, or many times we have to combine insulin with oral hypoglycemic agent to potentiate the action and to help the weight maintenance. So combination of lifestyle change, exercise, physical activities. They say people like us, doctors and chartered accountants, sit in the chair and give all kind of advice to the patients. When 6 hours you spend in a chair, by just sitting in chair for 6 hours, it is equivalent of smoking 20 cigarettes a day. If you just sit for 6 hours doing nothing, therefore I always stand up and talk, or keep on chasing in my clinic while talking. Even if I am using a mobile, I walk and I talk, because that's the only way to remain active. You should use staircase instead of elevator. Only sitting for 6 hours is a big risk factor. So you change that. And remember, one inherent problem, in fact that is a pharmacological action with insulin, is what is known as hypoglycemia. Remember, your blood sugar is high for 10 years, about 200. Nothing will happen, or something will happen maybe later. But blood sugar going lower than 50 once or twice, and that during the sleep, can be fatal, can invite atrial fibrillation, cardiac standstill, and therefore hypoglycemia is one thing which is easily avoidable with a patient, particularly taking insulin. Remember, hypoglycemia with oral drugs is still more serious, because oral drug is like a revolver, is like a bullet which has been fired from a revolver. You cannot retrieve it. While the advantage of insulin that the flexibility of dosage is so small, if the patient is getting hypoglycemia with 10 units, you can make it 4 units, 2 units. So this minor adjustment of insulin dosage are very well known, and you can give just a short-acting insulin 3 or 4 times a day if you want to avoid the hypoglycemia due to long-acting insulin. So that's how insulin-related hyporeactions are lots lesser than the ones which are produced by long-acting sulfonylureas and long-acting drugs which produce prolonged hypoglycemia. Now, hypoglycemia has to be immediately judged. Hypoglycemia symptoms can be varied. Some symptoms are due to blood sugar going low in the brain. We call it neurogleukopenia, and they are right from drowsiness, dullness, lethargy, and there can be irrelevant talk, behavior like a drunkard. Many hypoglycemic patients have been locked up by police thinking that they are under the influence of alcohol. And particularly with the patients long-standing diabetes, if they develop hypoglycemia, they can develop permanent brain damage. So this you have to remember. Then the only treatment for a hypoglycemia quick response, we can do it at home, is taking 4 teaspoonful sugar dissolved in water. Don't wait for glucose powder to come. When your table sugar, sucrose, is dissolved in water, it becomes glucose. You give a glass of water containing 4 or 5 teaspoonful of sugar, immediately it restores the sugar back. A lot of people make a mistake. They feel slightly dizzy, drowsy, and hypoglycemic symptoms. They are aware. They help themselves with chocolate. Now that's the problem. Chocolate will not immediately rise the sugar. Chocolate will increase your blood sugar after 4 hours, 5 hours. Then he checks his blood sugar 2 hours after lunch, it is 400. So he's frightened. So what is this happened? So best way is to take 4 teaspoonful of sugar, dissolve in water and restore. And most important thing with the patients on insulin, they must have frequent monitoring of blood sugar. Now there are nice gadgets available known as CGMS. You can put a sticker here which records your blood sugar all the time. There is a reader. With the reader you can keep on checking sugar maybe every 5 minutes. While this is pricking, unpleasant. You can't keep on pricking your fingers 10 times, 15 times. But this is more accurate than this, because this sticker which gives you sugar sometimes maybe 20 to 30 milligram more. But a consistent more sugar between a gap of 25 to 30 from the finger prick to this is more reliable. Then you know that this is 180 means actually in reality is 160. But therefore diabetic insulin therapy along with monitoring is a team member. It's like Tabalji and Gayak. You cannot separate them. You have to have good monitoring system if you are on a regular tight control of diabetes. Not many times patients are insisted by their physician that I want HbA1c, particularly diabetic pregnant ladies, we want their HbA1c less than 5.5. Now less than 5.5 and a fasting sugar less than 100, post lunch less than 140 is virtually tarevarchi kasrat. You have to have so many factors in such a way. But a pregnancy is short-lived. It's 9 months. Mother does not mind doing anything during that time because she wants a healthy baby and a smooth delivery. But lifelong to live like this, it's a great deal of mental preparation. But while doing that, there is always a danger of overdoing it, and hypoglycemia is an inherent risk of a tight diabetes control. Now you should also know that the hypoglycemia can happen due to unaccustomed exercises. For example, if you are walking every day, say at a pace of 3 kilometers per hour, and regularly you are walking for about 1 hour, and suddenly one day you decide to walk more just because some young girl is also walking with you and you want to chase her. Nothing wrong in that. But the point is, she's so well tuned and toned, and she's about 10 years younger than you. You forget that and you try to chase her or walk with her. Your heart rate goes up, your energy consumption worsens, and you can develop hypoglycemia or even cardiac abnormalities. So, unaccustomed exercises should be considered. This happens many times. You are on the 7th floor, one day your lift is not working. You say, "Oh, so what? I am not well tuned. I'll climb up." 7 stories you have walked. After that, you decide I have to wear a nice shirt and all, I'll iron. Remember, ironing for 20 minutes is like walking 20 minutes. If you iron your own clothes for 20 minutes, it's like taking. So, some amount of unanticipated, unaccustomed exercise if you take, your sugar is bound to go down, and that's the time you should monitor. If the sugar is low, take sugar, or to sustain that sugar after spiking it a little bit, you must take a complex carbohydrate, so you will have a sustained release of blood sugar. Like after taking 2 to 3 teaspoonful of sugar in the water, you can take a slice of bread and apply a little bit of jam on that. So let this carbohydrate remain in your stomach for about 2 to 3 hours. So it releases sugar slowly, not sudden sugar, right? And then lost. So slow release of sugar, complex carbohydrate like wheat, bajri ki roti, paratha, all those things can remain for a longer duration of time in the body. So this certain disciplines you have to maintain when you are insulin. Now the third issue about the insulin is the storage. Ideally, all insulin should be kept between 2 and 8 degrees when you are not using it. But when you use it, take it out for 10-15 minutes and try to bring it to at least the level of 25 degrees, not exactly the room temperature. And when you are traveling, don't keep the insulin into your glove box in a car. Keep it in a nice ice packet or in an ice cooler so that it does not get destroyed. Heat is a big enemy of insulin storage. So that you have to take care. There are nice bags available. In that you carry insulin. You can carry insulin anywhere. You can carry it on board. As soon as you land the aircraft, board the aircraft, give your insulin packet to the air hostess. She'll keep it in the fridge. Always remember, if you are going to USA or maybe in other country, carry your insulin, but don't try to put it in your check-in baggage. Because check-in baggage, the temperature inside the belly of the aircraft is sometimes minus 20 degrees. And then sometimes if there are connection flights, the checked-in baggages are kept outside. Well, via Dubai you are going, for example. Then the Dubai temperature is 35 degrees. So carry your own insulin with you all the time. Although it may be a large amount, large number. Suppose you are going to USA for a period of 1 month. Carry insulin for 3 months. Because first of all, it is not available without prescription there of the local doctor. And what you pay in India in rupees, you pay that in dollars in USA. So make sure that you have got a good provision of your, and always carry sweets in your pocket. Best is sugar packets. Best is sugar packets, they are available, and carry some biscuits. Always carry food with you, even if you are going for a short journey. For example, say you are going to Pune. The Bombay-Pune, this beautiful road, 2.5 hours. But sometimes it can take 10 hours because of traffic jam. And if you are stuck on a highway without food, and you're taken a shot of insulin in the morning. This situation should not come. You should be able to check your sugar and should be able to take your snacks or lunch on the highway. There are facilities available to eat food, but you don't know what kind of quality of food you get there. But carry your own food with you. This is a bag that you should always carry when you're on insulin. Now, there are certain aspects of insulin that incremental dosage. Now, these are for stable people that we have talked about. When does the insulin requirement go up? There are 3-4 situations if there is an infection. Infection, it can be overt or an occult. Overt infection is very, very subtle. Tooth abscess, urinary tract infection, boils which are in an area which are not seen by you. Your boils in the arms and all parts and pockets are evident, but they could be in groin and you have missed it. Or a tooth abscess. They are all occult infections. Tuberculosis of the lung. Patient may not have any symptom. Miliary tuberculosis. COVID was one condition where suddenly the insulin requirement went up. So, associated infective conditions can increase the insulin requirement. If a man is well controlled, normally a person in the non-diabetic person produces 25 to 40 units of insulin in a day. So you calculate that supposing you need 40 units of insulin from outside while you are on insulin therapy, in a situation, suddenly your insulin requirement goes up 60, 70. Suspect you have got two conditions. One is infection, second is infarction. Now what is this infarction? Myocardial infarction or a cardiac abnormalities in a diabetic patient sometimes come without the conventional signs and symptoms like chest pain, uneasiness, breathlessness. This is what you see in a cardiac patient. These symptoms may be absent in a diabetic patient of a long duration because of damage to the autonomic neuropathy. This happens in a patient who has got infection, and sometimes occult infection means not evident. There is no boils, there is no pus, there is no abscess. You see either a tooth abscess where you just get a toothache but there is an abscess in the root of the tooth, or infarction. Myocardial infarction produces a classical symptoms in people with such as chest pain, vice-like pain, breathlessness, uneasiness, abnormal pulse rate. All those things sometimes are absent in diabetic patients due to long-standing diabetes and due to autonomic neuropathy. They don't classical symptoms of heart attack. In fact, many of them get what is known as silent myocardial infarction. When a routine ECG is taken, they find that he has had heart attack 3 days back. The man had no symptoms, he was walking about. But sudden rise of insulin requirement must give you warning signal that there is something else is going on in the body. And these two things are common, infection and infarction. Then of course, some ongoing immunological process, ongoing autoimmune phenomena, autoimmune allergic manifestation, many diseases like tuberculosis, sarcoidosis, renal disease, they all, if the sugar requirement goes up for no obvious reason, you must investigate patient thoroughly, including all tests. Sometimes you may have to do even a CT scan. Sometimes you will be surprised, a diagnosis of cancer also can take place, and if you may have no symptoms of weight loss, fever or fatigue, but you have some quietly sitting tumor in a liver, sugars may go up. So that's the reason. Must remember one thing, concomitant drugs like corticosteroids. A lot of patients take steroids for various conditions like arthritis, like certain immunological disorders, like asthma, they are on steroids, a small dose. But the steroid dose goes up sometimes, and the steroids can increase blood sugar. Anti-malignancy chemotherapeutic drugs can also increase blood sugar. Now, these are the things where you need to manage the patient more aggressively. Third area where you need extremely meticulous control is surgery and critical surgeries, CABG, cancer surgeries, and general GI surgeries, where you need a very aggressive approach in giving insulin, and sometimes you need to give insulin infusions, either in a form of a pump or in a form of a continuous insulin infusions. This to tide over the crisis, post-operative period of the CABG, post-operative period of a certain malignancy surgeries like esophagus, Whipple's, or hepatectomy, lobectomy, certain very aggressive, very mutilating big surgeries. You need a higher dose of insulin. Neurosurgery, head injuries. The head injury patients sometimes may need as much as 200 to 300 units of insulin a day. So that is another thing that you have to keep in account. Then of course, diabetes in pregnancy is a separate chapter altogether. You have to see that the child's weight does not go too much. The only way to suppress it to give exogenous insulin so that the child's pancreas does not produce insulin to counteract mother's elevated blood sugar, and therefore you have to monitor patient frequently and keep a target of HbA1c of 5.5. There are many other conditions associated with diabetes which can demand more insulin, particularly type 1 diabetics during puberty and adolescence, when the child is developed into a man or a woman. The hormonal changes that occur, they can demand a lot of insulin. So that has to be considered separately. So far we have just talked about type 2 diabetes, we have not talked about type 1 diabetes. And type 1 diabetes of course cannot live without insulin. You have to really put out that child to go on insulin. It's a big ordeal how you do it. But with insulin they live a normal life. And insulin, they can go places. One example I like to give always is Wasim Akram. He got a diabetes at the age of 14 and he took 500 wickets in first class cricket. So diabetic children can live a perfect, fruitful life, but certain amount of discipline, certain cooperation from teachers, school, classmates, all these things will help a type 1 diabetic overcome problems of insulin. So friends, this is in a nutshell about insulin. I mainly covered the role of insulin in type 2 diabetes. And I'm sure over a period of time, there could be a lot of people who will come forward to take insulin from tablets because of one good beneficial effect. You should know that insulin is after all an anabolic hormone. It improves your muscle mass against catabolism. Catabolism, breakdown of body protein. And against catabolism, insulin helps you gain weight, healthy weight, takes away hyperglycemic malaise, makes you feel good factor, what the people talk, energetic, and you feel happy, and you live definitely a longer life when you take insulin early. Early initiation of insulin is an art, because then body has got what is known as metabolic memory or legacy effect, a tight control executed in the first 10 to 12 years of the life of a diabetic has a rewarding results, and particularly early initiation of insulin will definitely help most of my diabetic patients. Thank you very much.